we will be sharing it. So be mindful of what you put in the chat box. Please, let's be decent and respectful to each other in terms of the comments that we put there. The chat box can be found at the bottom of your screen. For those of you who are not familiar with Zoom, please put any questions or comments here for our panelists to see. Thank you very, very much. I will now invite our panelists to introduce themselves. So we'll start with Dr. Mathias. If you could please introduce yourself. Sam, could you? Yeah, so Dr. Mathias. Mm-hmm.
Hello. Hello, hi. Good afternoon to you all. My name is Dr. Mathias Chinyandura. I work as a consultant anaesthetist for Leeds Teaching Hospitals NHS Trust. Work at the LGI and Chapel Allerton Hospitals in anesthesia, theatres and intensive care. I also work for the University of Leeds as an honorary senior lecturer. I look after and teach 3rd to 5th medical students.
Thank you, Doc. Thank you very much. And now, perhaps if we could introduce Cllr Abigail Marshall.
Good afternoon, everyone. Lovely to see each and every one of you again within a week or less than a week. My name is Abigail Marshall Katung, local councillor representing Little London, Woodhouse and the city centre. I'm also the lead member for BAME and also chairing the board of 16 to 25 years old for in further education in the city. I also work as an England athletics coach where I specialise in sprinting. So lovely to see you all and be part of this conversation, and I look forward to it.
Thank you, Councillor. Thank you very much. And last but not least, Xina Broderick.
Hello, everybody. It's nice to be back again. I am a funeral director. I own Gooding Funeral Services in Leeds 7 with my husband, Peter, and my sister, Gay. I'm also an executive coach, and I've had COVID-19 too. So I'm here to talk about those things and engage with the other panelists.
Fantastic. Thank you very much for joining us. So without further ado, I am going to hand over to our Director for Communication, Lucy Ndlovu, who will be handling this session. We are going to have 3 sections to the session. So the first one, we are going to have Dr. Mathias introducing us to, telling us a bit more about COVID-19. Then we'll go into sections where each of our speakers will share as directed by Lucy. Then we will go into a more Q&A section before we end with our 3 speakers giving us some tips that we can take home with us today. So without further ado, Lucy Ndlovu, it's all yours. Thank you.
Thank you. Thank you, everybody, for joining us again. We are happy you're back. We're extending you a warm welcome from Yorkshire and also from the African community. And you know, as Africans, we are renowned for our hospitality. So thank you for joining us. So without further ado, what I'll do is I'll go through some BAME COVID statistics. And that's because COVID-19 has affected all of us. When we look at the people who've been affected, there are people who look like me, who look like you. And indeed, we've got Xina here, who has obviously been touched by COVID-19 and thankfully she's recovered. So this is not something that's removed from us. This is something that's very close to us, personally, as a family and families, and also as a community. Okay, so I'll go through the statistics that I've got, and I managed to get some more this week from the news, just so that we know where we are with this. Okay, so the latest ones show that according to NHS England, it shows that death in hospitals account for BAME community account for 19%. Okay, and obviously, as I go through these statistics, they're obviously quite concerning, heartbreaking, and appalling, to be honest. And the 19% I mentioned, that's 4% higher than the population we currently are in the UK. Again, it says here that this week Sky News analysis found that 64% of health workers who've died of COVID-19 are from BAME, and that's a huge number, 64%. Again, very worrying. And also 21%, the workforce in the NHS are from BAME. We know that, we've seen that in the news, we've seen the statistics. But I think the most worrying one for me this week that I came across is that if you're from Black African origin, you're 4 times more likely to die of COVID-19. So that is worrying. And that is why we're here. That is why we want to understand why is that, you know, what is inequalities, and what it's still unclear where that is. And they're looking into it. Obviously, we know there's research that's going into this. So without saying anything else, we can't argue with the facts. The facts are what they are. And what I'll do is I'll pass this on to Dr. Mathias to give us an insight from a medical perspective based on his own experience. Obviously, he's in the front line, and also his own research as to maybe why this is happening, and that is why we are here. So Dr. Mathias, over to you.
Thank you very much, Lucy. Thank you very much, Candy, for inviting me to come. So rather than just go straight into the issues with BAME, I thought what I would do is I would just talk about COVID as a disease so that we all understand what it is. And then after that, then we can go into the issues that are affecting BAME. So just to start, I'll just start with a quote from Boris Johnson. He's our Prime Minister, as you all know. He was in intensive care unit with COVID. So when he came out, he said that we've come through a peak and we've been going through an alpine tunnel, but we can now see the sunlight in the pasture ahead of us. It is vital that we do not lose control and run slap into a second and bigger mountain. And I think he has put this in a very poignant way, for all of us to understand what is going on here. Personally, I think that this is not the beginning of the end. This is actually maybe the end of the beginning, because life as we know it is probably going to change. As you all know, 6 months ago, COVID didn't exist. And in fact, up until 6 weeks ago, life here in the UK was almost normal. But from Monday, we will know what that new normal is going to be. And I can certainly say it's not going to be the same. 30,000 people have now died in the UK. So just as a summary of what I'm going to talk about, I'm going to talk about, what COVID is, a bit about the virology. We've all heard about this R value. And then I'm going to talk about symptoms and risk factors, and then the clinical management of it, and then the public health side of it. And then I also thought I would just talk about, ventilators and PPE, because we've all, been bombarded, in the media. And some people don't actually know what a ventilator is and what PPE is. And then we'll go into the BAME issues. So first things first, what is COVID? Right, so I'm just going to run through some of the terminology. So basically, COVID is an acronym that just stands for Coronavirus Disease of 2019. So this was coined by the WHO on the 11th of February. So it is a completely new disease which is caused by a virus which they have now called SARS-CoV-2. So it is SARS-CoV-2 because there already is a SARS-CoV-1 virus, which is just called SARS-CoV. And this virus, it did cause a small outbreak. I think it was in 2003. I think it killed about maybe 1,000 people or so, but it was contained. So this SARS-CoV-2 virus is a member of a family of viruses called coronavirus, of which some of you might have heard of MERS. That's another one. And also some of the common cold that we get is actually caused by coronaviruses. So initially, the Chinese scientists, when they discovered that something was happening, they called this virus nCoV-19, just meaning novel coronavirus, novel just meaning new. So that's what they called it. And then the WHO then has formally named it SARS-CoV-2. So it is a virus. So as you know, viruses cannot exist on their own, bacteria can. So if you leave a virus outside, it cannot replicate. But bacteria, if you give it food, it will multiply. So that's the main difference between viruses and bacteria. And the other difference is also in the size. So the size of the SARS-CoV-2 is between 40 to 200 nanometers. So just to give a little bit of perspective, if a bacteria is the size of a football, so the coronavirus is probably just the size of a grape or even smaller. And the way it infects human beings is through the respiratory system, and then it attaches itself to an enzyme that is called an ACE2 receptor, which sorry, I've just lost my the ACE2 receptor. If you just go back on the slides, I think you are a little bit ahead of me. Yeah, terminology. Yeah. So as you can see, so that's just like a schematic diagram of the virus there. So the yellow bits are the spike proteins that it uses to attach to this ACE2 enzyme. I keep saying something about this ACE2 enzyme because it is the enzyme that we think is linked to people who are susceptible to it in a genetic way. So this is the enzyme that we think is responsible for that. So transmission is direct or indirect. So direct is from coughs and sneezes. And if you are within 2 meters in distance to the person that's infected. And this is the reason why, the social distancing, they are emphasizing a lot about being 2 meters, not being 2 meters from somebody. That's the reason why. And then there's also another cause of direct transmission, which is what we call an aerosol, right? So an aerosol is fine particles which do not settle down on surfaces, so they just hang in the air, and they can also cause infection. Indirect transmission is usually due to droplets which settle on surfaces, and then they contaminate them, and then if an individual then touches those surfaces, then they can infect themselves, by touching their face, their eyes, or by their mouth. So what is this R? So R just stands for reproductive rate. So as you can see in the picture there, it is just a measure of how many people one individual can infect. So if R is 1, it means that one person will infect one other person. If R is 2, then one person will infect 2. So the reason why we need to know about R is that if you want to control an outbreak, then R needs to be less than 1, because then that way the infections will be getting less. If R becomes more than 1, infections increase, and they don't only just increase, they increase at an exponential rate. So that is why this is so important. So the R rate for SARS-CoV, so there is something called a basic R, and the basic R basically is an R when there are no measures at all. So it's a measure of how virulent a virus is. So we think that for SARS, it is between 3 and 5. And our current rate has been reported to be between 0.5 to 0.9. So you can see that our measures that are being taken are actually working. So symptoms, so you've got classic symptoms and what we call cluster symptoms. So classic ones are your persistent cough, sore throat, fever, headache, myalgia, which is just basically feeling lack of energy, muscle aches, fatigue, and then difficulty in breathing is a very late sign. So that one happens when somebody has has had lack of oxygen for a long time, and then they start having difficulty in breathing. The cluster signs, so these usually we just use them together with others. So abdominal pain, diarrhea, loss of appetite, and what we call anosmia, which is just loss of smell and taste. So risk factors, I think we now are quite familiar with these. So age, more than 70. Race, as we've all seen now, that BAME are at increased risk. This has actually been estimated to be between 20 to 90% increase in risk, which is adjusted. So gender, male gender, underlying medical conditions. So we've all heard about respiratory disease, cardiac disease, diabetes, cancer, HIV, renal disease. And then medication. So this is important because I talked about that ACE enzyme. So we use drugs that are used to control high blood pressure, and they work on that enzyme as well. So we have found out that some people who take these medications actually are at increased risk of COVID. Then poverty and overcrowding, occupation, healthcare workers, obesity. If your BMI is more than 40, you are at an increased risk. Pregnancy, has been reported, but from my own experience here in Leeds, we haven't had that many pregnant women. But it is one of the risk factors. So the typical COVID patient, right, is somebody who's elderly, who's male, who's obese, with underlying medical condition. And now we also know that if you are BAME as well. Right, so diagnosis is mainly clinical. The standard test is a PCR, which is a polymerase chain reaction, and basically it looks for particles of the virus, and you get this from a swab that has to go through the nose. And the important thing about this one is that that swab needs to go right at the back of the throat to go to the pharynx, because that's where the highest concentration of the virus is. So it is quite uncomfortable, but it needs to be done properly, because there is quite a high false negative rate if it's not done properly. Additionally, in hospital, we use chest x-rays and CT scans and blood results. Medical management is basically dependent on which of the three groups you are: mild, moderate, or severe. So mild, basically you stay at home, you self-isolate, and you do social distancing. It's because yes, you are unwell, but you are okay. You can look after yourself. Moderate is when you feel that you are getting worse and you can't stay at home. So normally you have to ring NHS 111, and then they will ask you to go to hospital where they will be expecting you, and you will be isolated. And we call that level 1 care. So it's just simple supportive care, and it's mainly involved just being given some oxygen, painkillers, or IV fluids. Because remember, these patients, they have that fever and it can dehydrate you. So sometimes they just need IV fluids, and they have observations done every 4 hours. Then severe COVID, that is when you need to go to intensive care or to critical care. And there are 2 levels of this. So level 2 and level 3. So level 2, so when somebody becomes severe and they need to go to intensive care, it's mainly because they need assistance with their breathing. So with level 2 care, they need what we call non-invasive ventilation, and with level 3 care, they need invasive ventilation. And the main difference is that with level 3, you are sedated, you need to have a tube, a breathing tube, and then you are given medication to sedate you. But with level 2, you're breathing by yourself, and you get what we call CPAP, which is just positive airways pressure. You get good outcomes with this one. The nursing care can be 1 to 2, and you get hourly ops. With level 3 sedation, you get continuous observations, 1-to-1 nursing, and the outcomes are worse. So if you need to be sedated and to have a breathing tube, the mortality is quite high. It's 50 to 60%. Then I'm just going to talk about ventilators, because we've had these mentioned quite a lot. So basically, a ventilator is a device that helps with breathing. So it can be invasive or non-invasive. Some people are actually, have ventilation at home. I'm sure, some of you have heard about people who've got sleep apnea or who have got COPD. So you can actually have a breathing machine at home. That is ventilation. But in hospital, it's more sophisticated, and we use, like expensive machines. So there's different types of ventilation. There's CPAP, there's BiPAP, SIMV, and the sort. So this picture here is just showing you what CPAP is. So on the left, that is a nasal CPAP, and this one, usually this one is used for sleep apnea. And then on the right, so that one is for COPD, somebody who actually needs help with their breathing. So this can be done at home. Now I'm just showing you some ventilators. So there are different types of ventilators. We've got portable ventilators, and then you've got the ones in ICU. So the red one on the left, so that is a portable ventilator that you find on ambulances. So all those ambulances that you see, they will carry a ventilator which looks something like that. So it's a small thing. And then the yellow one on the right is an ICU, it's a hospital ventilator that we use to transport patients, say from a ward to have a CT scan. So if you want to transport the patients within the hospital, that's the one we use. And then on ICU, we've got these big machines which are very expensive. So the one on the left, so that's an intensive care ventilator. So that ventilator will do pretty much anything. And then the one on the right, so it's actually an anesthetic machine. So it does something extra to the intensive care, because it can keep you asleep as well. So it can do ventilation, and then it can keep you asleep. So you can see the range of ventilators, and they all look different. So when the government said that they are they're going to need 10,000 ventilators, you've got all sorts of kinds of ventilators. And then actually, I'm sure you've also heard about the ventilator that the F1 team were asked to build. So basically, so that one is a CPAP device, which is a small device, and basically its job, right, is to deliver the CPAP. So it will work for level 2 patients on intensive care, or sometimes even on the wards. So those are the ventilators. Then I'm just going to come back to the pharmacological treatment of COVID. So as we all know now, COVID is caused by a virus. So there is no specific treatment for it. But at the moment, there are several drug trials that are going on, and because we are so desperate, any drug that we think may work, if you think of it, there is a trial for it. But at the moment, so there is a drug called remdesivir. So this is an experimental Ebola drug. It has been shown to work on SARS-CoV by reducing the length of stay in hospital from 15 to 11 days. So it is the only drug that we have at the moment that has worked. You've all heard about hydroxychloroquine. So this is the drug that Donald Trump was talking about a few weeks ago. It's an anti-malarial drug. Here in the UK, we use it for people with rheumatoid arthritis. But this drug, the results have been disappointing. Right? It's got a lot of side effects, and we're probably not going to use that one. There's another drug called Artemisia. I don't know if some of you have heard that the president of Madagascar is encouraging people to take this drug called COVID Organics, which is a herbal drink. Basically, the active ingredient in that is called Artemisia, which is a compound that we know can treat malaria. So he is claiming that this drug can treat COVID. And I think the WHO has now actually recommended that it should be put to trials to see whether it works. So some of the treatment now is plasma antibodies and vaccines. So the vaccine is the holy grail of treatment for viruses. We haven't got one. It takes a long time to develop one. So the next thing that you can give are plasma antibodies, which is basically someone else's antibodies who has had COVID. So you take those and then you give them to people who are suffering with COVID. Then I'm just going to come to the public health management of COVID. So we've all, now become accustomed to this curve of, flattening the curve. What does that mean and what's the importance of that? So flattening the curve, basically the yellow curve is what would happen if you didn't do anything at all, right? And then the line that's going across it, is the line where you overwhelm your healthcare system. So what you want is to bring the curve, the peak of that yellow curve down below the level of your healthcare system. So it should look like the blue curve. So that is what is meant by flattening the curve. And that is what all these measures are trying to do. And then the next graph, so that graph now shows the number of cases as they are happening. And we have succeeded, right, in getting that curve underneath the capacity of the healthcare system. I'm just going to talk a bit about protective, personal protective equipment, because I think this has been very, very topical as well. So what is it? So basically it is anything that protects you from an infection or from any risk. So it also includes just even washing your hands, soap and everything. But specifically when you're talking about infections, viral infections or anything, so it is head to toe protection. So the components are a hat, a cap, goggles or a visor, and then mask, gown, gloves, and footwear. So there's different types of PPE. So you can have just a simple PPE. This is what we normally use, if you are handling something dirty. So it's basically just a mask and a plastic apron with some gloves. So we call that simple PPE. And then you have what we call full PPE. So with full PPE, so it covers you from head to toe, and you have to have a fluid-resistant gown. And then you can have protection for your eyes, either as a full visor or as goggles. And then within the full PPE, there is what we call standard PPE or AGP PPE. And what differentiates these two is the type of mask that you wear. So with standard full PPE, you will wear a mask, which we call a simple surgical mask, which looks like this on the left. With AGP full PPE, you have to use a filtering mask, which we'll call that an FFP3 mask. I will talk a bit about those. So AGP simply means aerosol generating procedure. So remember I said that, transmission of COVID is through direct or indirect, and then within the direct you have this aerosol. So there are procedures that cause these aerosols. So intubation, this is what I do, this is my job, we intubate people. So that puts you at a very high risk because it generates this aerosol. That's why you need to have the FFP3 mask. And all those procedures, so manual ventilation, suctioning someone, CPR, when you're trying to resuscitate someone, bronchoscopy, So even surgery, when they use drills, high-speed devices, dental procedures, those ones, they are aerosol generating. So non-invasive ventilation, this is the reason why when somebody becomes severe COVID and they need that, they have to go to intensive care, because it is blowing oxygen into their face, and that generates an aerosol, and the rest of them. So the face mask. So you have a simple surgical mask, which is this one here, and then you have the FFP3 mask, which is one of these. The main difference on them is the size of the pores in the masks. So the simple surgical masks have got larger pores, and then they also leak around them. So it doesn't actually protect the person who is wearing them. So it will protect other people because it will capture those droplets. But with the FFP3 mask, so this one, so in addition to having very, very fine pore sizes, which will actually trap the viral particles, it also has a seal around it. So when you wear it, it is tight fitting and it will seal. So there's no leak around it. So it actually protects the wearer and others. One thing that you need to have if you're going to wear one of these is what we call fit testing. So you actually have to be tested that it fits you properly, because some of them cannot, do not fit you, and you have to try a different type. And then you also have to be trained. There is what we call donning and doffing, because you need to learn how to put the FFP on, and then also how to dispose of it correctly. Right, so now I'm just going to touch a bit about the BAME issues, what I think has been going on. So I'm just going to sort of touch a bit on the evidence, and then what do we need to do? What do we do? So we've all heard, we've been watching the news, we all know somebody who works in the NHS, and, on Facebook, you've seen all these people who have died. On the news initially, when things were starting, they would show a doctor has died, and you would see that they are, a member of the ethnic minorities. But then what also then happened was that data was now actually starting to become reported. So firstly, there is an app called a C19 app, which is basically an app that one of the universities in London developed, where people download it and then they self-report whether they have symptoms, and then if they get tested, then they will then report that. So they were the first ones to report that, BAME were reporting, higher infection rates. And then there is an organization called ICNAC, which is basically, it's an ongoing audit project by the Intensive Care Society. So they also then started reporting that the BAME community were overrepresented in admissions to intensive care and deaths. I think that is when the government, really took notice. And then the Office for National Statistics, then, this week have now also reported some data. It is, basically, unequivocal. It just confirms what, what all these other people were reporting. And basically, this is what the ONS have reported, that Blacks are 4 times more likely to die. And then when they have adjusted that, for other risk factors, which are associated, and they found that, that reduced slightly to about 1.9. So that is where that 90% increased risk of death is coming from. And that, Bangladeshi and Pakistani people are 3.5 times, Indian people are 2.5 times, and Chinese people are 1.8 times more likely to die. So this graph, I don't know if they're projecting very well. So that one is just showing the fully adjusted results. And the first one that I showed you was just showing the ones that they had adjusted just for age, because the reason why they put age is because we know that, you know, younger people aren't affected as much, so they try to adjust just for that. But still, you know, so that is the one that came up with the 4 times increased risk. And the graph on the right, is just showing the male to female disparities. So there is no doubt that, you know, males are affected more than females.
Can I interject a little bit, Doctor? We cannot see the graph, I believe, on the slide that you've shared with us. We are missing some of the slides or some of the data that you just talked about.
Okay. I think Sam is advancing the slides. So
okay.
It's not coming through. I'm not sure.
All right.
So what I suggest we could do for now, we could just go through the statistics, because we've still got another section where we will talk about.
Okay, I'll just finish off because I'm not too far. Yeah.
Okay, that's fine. Yeah, thank you.
So males are affected more than females, and the ratio is almost 1:2. So it's about 60% for males and 40% for females.
Okay.
Right. So the other evidence, you know, which has come from ICNAC is that BAME, so they are overrepresented, you know, like I said, in ICU admissions and deaths, because they also report that as well. And then the C19 app, all right, so that one was reporting that, you know, so COVID symptoms and positive test results were more in BAME. And then also one interesting thing that they also reported was that because they have access, there's a database for twins, and the twins were actually reporting concordance, right? So, you know, if one twin got COVID, the other one was also more likely to get COVID, which points to a genetic susceptibility to COVID. So I keep going back to that enzyme, the ACE2, you know, so that's probably where the genetic link comes from. So then low socioeconomic status. One thing that is, you know, sort of puzzling is that, so we know that, you know, poverty and low socioeconomic status is a risk factor, but that doesn't explain everything, because when you look at just the doctors, you know, who probably, you know, aren't in a low socioeconomic status, so 20 out of 23 doctors who died were BAME. So there is definitely something that is going on as well, which is not just low socioeconomic status. And then another issue that has come out is poor housing and overcrowding. And then occupation, right? So we know that, you know, the NHS is made up of 40% by BAME. So definitely if you're working in the front line in the NHS, you are at increased risk. I've seen a few things about, you know, low vitamin D, you know, as being associated with being susceptible to BAME, and, you know, whether you've got BCG or not. But you know, there aren't studies, you know, that have proven this. You know, this disease is still quite new. There is a lot of things that we don't know, and you know, we just have to you know, study it a bit more, right? So I think, you know, the government you know, needs to do quite a lot of work, you know, which takes me into, you know, what do we do now? You know, so first,
can I stop you there? Can I stop you there, Doctor? Sorry. We'll get to that part. That will be the next part in terms of what do we do now. I just want to say thank you so much for your perspective. I feel I know more now than I did, to be honest, since I started this. I've been educated even about the PPE. I had no idea there's a difference. you know, I knew there was a difference, but I didn't understand it as much. And I just want to say thank you very much. And on behalf of everybody, you know, you're in the front line, you're going every day. I know it's not easy. It's probably quite worrisome for yourself and for your family.
Yeah.
You know, we just want to extend our thanks and say thank you for that. We appreciate. I'll now pass this on to Abigail Marshall. Abigail Marshall is going to give us a perspective based on being a counsellor for Leeds, for one of the wards in Leeds. And if I can just pass this on to you, Abigail, just give us your perspective on the whole COVID situation. I know you're doing a lot of work behind the scenes that we do not know. Could you share that information with us as well? Thank you.
All right. Good afternoon again, everyone. Thank you very much, Doctor, for that very enlightening explanation. We learn each day as we go, and like Lucy said, especially with the PPEs, you know, it just kind of sheds more light into. Is that from me? Sorry, can you all hear me? All right, excellent. So thank you very much again, sir, for giving us your bit from the medical perspective, of which without that, I'm not sure we really understand what we're going through, because lots of times we're told this is an invisible disease. We're told it's a disease without a cure. We're losing loved ones. We're losing, you know, when we look at the death, especially when you know people who have actually lost their lives from this disease, it just brings it all back home. And it has brought a lot of us together, especially in this city. I mean, since I was born, I have never, ever seen anything like this. And it has actually, within the council, especially within the councillors, it has just really humbled us. And we have now learned that together we are actually stronger, which is actually the motto and the ethos of the Leeds African community. And we have all of a sudden forgotten that we are BAME, we are from Europe, we're from Asia, and we all have just come together as one body to be able to tackle this disease that is killing every single, no matter who you are, no matter your status, are being affected. From the council's point of view as well, before we got into the serious aspect of COVID, there were a lot of myths about COVID, and especially with the BAME sector. People were telling us, oh, it's not for Black people, until Idris Elba got it. In fact, my sons came home and said to me, Mommy, we're fine. The three of us won't get it because it's not for Black people. And the moment Idris Elba got it, everything kind of changed for lots of people. And then we had the myth as well saying, oh, if you travel and live in hot temperatures, you know, like people from Africa where, you know, it's very sunny, you'll be okay. And believe it or not, a lot of people that I know were actually traveling home because they thought their countries were very warm and they will not get COVID until everything has changed. And obviously when our Prime Minister caught it as well, it showed a lot of things, because we started seeing celebrities, people who are really rich, that, you know, they don't need to clean their homes. There are people doing it for them and they could get it. So the whole combination of things that has happened has made each and every one of us look at COVID and deal with the way we live every day differently. So the first thing the council did was to partner with Voluntary Action Leeds, who are looking after different third sector organizations within the council. So we've got 33 wards and 99 councillors. So we've got 3 councillors per ward. And what the council did via and with Voluntary Action Leeds was to choose and commission a third sector establishment and organization in each ward to deliver the COVID-19 response on our behalf. So for my ward, we are working with a charity called Oblong. And what we did with Oblong, so all the calls that are coming through from people around the city who are seeking different kind of assistance, from food to clothing to helping with dog walking, with medication. We have one dedicated line for the council that goes through the council. The council will now ask you where you live, where your postcode is, and you will be directed to the hub that is looking after each ward. And then that hub that is looking after each ward, we have dedicated volunteers in each ward that will actually carry out that assistance to whoever needs help in the council. So that's what we're kind of doing in terms of helping each ward and its residents in terms of first call response. Now, on the business side as well, we obviously, lots of you who own your own businesses, the government gave grants. They also gave grants in terms of companies who could furlough their staff. So there was up to 80% from the HMRC that could be given back to you once you follow the guidelines and you're eligible. What I also found out, especially with a lot of BAME businesses, we didn't qualify. So lots of cases that has come through my inbox in terms of the rates and the guidelines in which the government had provided, a lot of BAME businesses could not qualify for the grants from the government, and that was a problem. So again, a case has been made to be able to assist all those businesses that did not fall under that category, where they could get certain £10,000 up to £50,000 grant from the government. So now they're looking into a new discretionary funding where businesses that did not fall into that criteria or were not eligible for the first grants that was awarded by the council can now benefit from that. So I will also ask for those of you here who own businesses, or you know other people who own businesses, be patient with us, but send through your emails because we're dealing with them one after the other. In terms of death, currently as of the 6th of May, cases confirmed in Leeds was 1,555. We sadly had 21 new cases yesterday, and in total we've had 265 deaths in Leeds, which is quite sad. That is high as well for Leeds. But for some reason, even though we've been going through the BAME statistics, that has not really, in terms of high figures, affected Leeds compared to London and Birmingham for so many reasons. With the ONS report that we have just received, the highest death rates that we have in the city has actually, the highest is actually Seacroft, and it's mainly elderly as well. So lots of times, because when I hadn't seen the stats, in my head, I was looking and saying, oh, as soon as these stats come through, we will be seeing places like Hare Hills, Little London, Bournemouth, Richmond Hill. But you see, our cases in those areas, for some reasons, has been quite low. We've also received a lot of cases and reports from our BAME healthcare staff, particularly because I'm a lead member of BAME in the council. I get a lot of calls from healthcare assistants complaining about what they're going through in their respective places of work. Obviously, we had the issues with the PPE, which is not just unique to Leeds, is across the whole country. We've been having problems saying that they were not provided with enough PPEs, especially at the start of this pandemic. I have spoken with a lot of healthcare staff as well who have said what they feel has caused a lot of them to have this disease or have died from this disease. A lot of our healthcare staff are unable to, are kind of afraid to seek care, also afraid of also refusing intervention. They also feel that they are placed in more COVID wards than the rest of their colleagues. I also have a friend who I had to tell her off because she was looking after about 16 patients, of which 11 of them had COVID, and she was working back-to-back nights every day. And she said she had to because that was her only job, and that if she didn't do it, she will not get paid. So a lot of us are doing what we're doing, especially our BAME population who are in the healthcare, who are in the front line, for so many reasons. Culturally, we find ourselves as BAME people very different from the rest of the world. So I grew up knowing that I have to look after my brothers, sisters, and parents. Until I came to England, I realized that, oh, when your parents get old, you can take them to a nursing home. So most of us live with our parents and care for our parents. Now, just not your parents, we also care for extended family. So you find that a lot of our people who work in the care sector, and not just the care sector, every other place, are burning the hours because we're consistently working so hard to provide for everyone, not just our immediate family. We're working hard and still sending monies back home. So we're not resting enough. We're doing all the shifts in the world. I run an agency as well. So you find out that all the shifts that lots of the other nurses and doctors are not wanting to take, the people who are going to take them with everything inside of them are BAME people. So we are putting ourselves out there, doing the shifts that nobody wants to do, and obviously exposing ourselves to the risk of contracting COVID-19. Yes, we're 4 times higher in terms of catching this disease, but obviously I'm not a doctor. It's sad to hear that. What can we do about it? That's why obviously with the research going on and the reviews going on, I am really looking forward to seeing these figures. And then to also think that is our men as well are more at risk than our women. So these are all the questions that we're also asking. I wish I had answers for all of you today, but I really don't. But the only thing I can say, because we know how this disease can be contracted, we have to look after ourselves. Those of us in the front line working, do not work more hours than you are required to work. If you need to rest, because it's also down to a lot of immunity and how much our bodies can fight certain things. Yes, we know that working 7 nights and looking after 11 patients out of 16 that have got COVID, there are lots of things that you're exposing yourselves to. So we have to ask ourselves, there is the money aspect and there is my life and children, that if I'm gone, who is going to look after them? So these are the things that we have to challenge our BAME healthcare staff who are putting themselves in the front line. And like again, I said, it's a catch-22 because lots of them are doing it because if they don't do it, they cannot earn. But we also want to let you know that the council is here to help. I know the council cannot give every single person enough money to look after their families, but I will say it's only when you have life that you have hope. I'm currently also working with the National Institute for Health Research, trying to see how the BAME population can open up and accept the trials for this disease. Because if we're asking the questions about why we are more at risk, and if we're not putting ourselves forward to be able to be tested to see why, then we're not going to be able to get the right answers that we need. So we will be contacting yourselves very soon. And when we say trials, I know we're very skeptical. Africa says, oh, no, I don't want to be used as a guinea pig. They've seen the person they want to see used to die and kill. That is not the case. Trials does not necessarily mean vaccines. So we have to be able to trust our researchers, trust our clinical practitioners when they come and approach each and every one of us saying, these trials are taking place, and because BAME people are at higher risk of contacting the disease and also dying, please let's put ourselves forward and join this trial so that we can help the clinical world doing this research in order that we can find cure. Because you can imagine, I mean, look at the numbers that we're, over 30,000. We're now the country leading in the highest number of deaths of this disease in the world. That is very painful. So somehow, as ethnic minority people, we have to look after ourselves because nobody can do that for us apart from ourselves.
Thank you so much. Thank you
that will
for now. Thank you. Let me cut you short. You're very passionate about this, and thank you so much for that information. For those of you who are from Leeds, I'm sure you've heard of the support that the council is offering. If you need any more information, we'll be able to put it on our website for Leeds African communities in case you didn't catch any of that. So if you, after this session, we'll be able to share the information that you need. Now, last but not least, I would like to introduce to you Xina Gooding Broderick. And I would like Xina to sort of speak to us about her experiences of COVID and as well as what she does. And of course, Xina herself has experienced it, obviously, and her family, she says. So when you're talking about putting yourself forward, Abigail said that she would be one of the people who would be able to tell us how it feels like, because it's a real experience for her. So over to you, Xina. Thank you.
Thank you. I'll just say a little bit about my initial experience. I started to go to bed earlier and earlier because I started to feel quite tired early. This wasn't unusual for me because I do go through phases where I try to get up at 5 a.m. So I go to bed at 8 or 9 p.m. to accommodate. But I found that even though I was going to bed early, I was still tired. I became super grumpy and unusually grouchy. For those of you who know me, I'm quite an upbeat and positive person. I certainly was not upbeat. I certainly was not positive. I was actually positively a monster. I wasn't very pleasant to be around at all. And I can tell you what my symptoms were. And I'm going to say these symptoms very, very specifically. I had no cough. I had exhaustion. I had difficulty breathing for a couple of nights, and that was quite painful. And I had exhaustion. I had loss of appetite and exhaustion. I had loss of smell and exhaustion. I had confusion. I had exhaustion. I had headaches and pain. I had exhaustion. Are you guys understanding what my overall feeling from this illness was? I was absolutely exhausted. I was speaking to a friend of mine who has had, he's like a brother friend of mine, he's had pneumonia, and he said, Xina, the way you're describing your exhaustion is kind of like how I was when I had pneumonia. And let me tell you a little bit to put this into perspective. I consider myself to be quite a healthy person by nature. I have a plant-based diet. Downstairs, I've got things like moringa. I've got natural cacao. I've got all sorts of herbs and stuff. I've got a high-end blender because I love my smoothies. I've got a juicer. I've got black seed oil. Any kind of remedy you can think of, I've got. Did I use any of the remedies? No, because I was exhausted. I had no oomph. I had no get up and go. All I wanted to do was sleep and sleep and sleep. I have a big bottle of water. I drink something like this every morning. I was not drinking. I love my herbal teas. I drink them throughout the day. I wasn't drinking those. So I know that my dehydration will definitely have impacted on my response to being as ill as I was. I was very concerned more for my husband because he did have a high temperature. He was coughing. He was vomiting, as the doctor said. You know, we don't really hear much about vomiting and diarrhea, but my husband did have vomiting. He did have diarrhea. His breathing was very labored. So I would get up and go and get something for him because I was frightened that he wouldn't last. I was really, really quite afraid for him. I've been asked what kind of help from the community or NHS support did I get? I didn't ask for or receive any NHS support. And I know that the doctors mentioned, you know, there is a COVID-19 line that you can call if you have the symptoms. I tried calling, the line was engaged for 100 years. Well, it seemed like 100 years. It could have even just been 5 minutes. But I was too tired. I could not wait. I needed to sleep. I constantly needed to sleep. And even when I woke up, I felt okay for a little bit, but then would be exhausted. So I couldn't do any cooking or anything. I couldn't stand up for too long. And I have to say that has to be, for me, that was definitely the worst, and worrying about my husband. My son, who is 9, he lost his sense of taste. He lost his sense of smell. He did not have a cough. He did not have a temperature. He lost his appetite. And if any of you guys know my son, you will know he loves his food. So the fact that he lost his appetite was a real sign that he wasn't well, he wasn't his usual self. And he was sleeping a lot longer. But he didn't know he was even ill or had COVID until we told him afterwards. And we only knew that because the loss of sense of taste and smell was quite a big symptom, a common symptom. I should also point out that one of my sons was in China when all of this broke out. He was doing his year out there. He's studying international relations and Mandarin, so he was doing his year in immersion for his language skills. And we knew quite early on in January that this was an issue, and we really, really wanted him to come home, because although he was quite far away from Wuhan, we thought that if it does start to spread and we want him to come home, we might lose the opportunity for him to return. So we just thought we'll keep things, we'll be as safe as possible and bring him home. So my goddaughter was living with us at the time in my son's bedroom, which meant that when he returned, he needed to go into my youngest son's bedroom. My youngest son slept in the same bedroom as me and my husband. He had a Z bed at the foot of our bed. So there were 3 of us who had it, all in the same bedroom. There were 3 others in the house. That's my eldest son, the son who came back from China, and my goddaughter. They did not have any symptoms, and they steered clear of us. They were doing their own version of isolation. But we think that it's more likely that because of my husband's clear symptoms, even though myself, my youngest son and my husband had very different symptoms, we are confident that we did have COVID-19. I'm just going to check and see if there are any other questions that I was asked, because there were a few that I've had. One of them,
yeah. Go on, Xina.
One of the questions that I had was, in my view, how do I feel myself and my family contracted the virus? I've been asked that question lots of times, and I would say that it's just really hard to say. I felt like the children were in school longer than they should have been. It wasn't clear to me initially that they were super carriers and are more likely to carry the COVID virus without anybody knowing. That wasn't made clear to me until a French friend who was under lockdown sooner than we were pointed that out to me. I did direct a funeral during between us becoming very aware of the dangers in the UK and the time that we went into lockdown. So it could have been from friends, it could have been from clients. Peter, my husband, was more active in the funeral business. He could have got it. We could have even gotten it from inadvertently touching our faces after, having handled the shopping trolley. It's just really hard to say. It's really difficult to say. So Lucy, you wanted to ask me a question.
We're running after time, so to speak, and we're trying to sort of get you to speak a little bit more. I mean, obviously what you do, being a funeral director, and also we've touched on the cultural aspect, obviously coming from, BAME, even if you say Black people or African people, when someone is affected and passes on, or those kind of things. There's a cultural aspect to this, how we do funerals and how we mourn and how we want to get together, and how, if you've seen that, now, and how that's going to affect, going forward. Maybe just, if you could just talk to us about that. You haven't got long, so if you could just summarize it for us. I'm sorry.
Yeah.
But yeah, it'd be useful, very useful.
I'll be as quick as I can, just to say these very important points. Everybody internationally, irrespective of race, we grieve.
Yeah.
the impact that the social distancing has on the Black community, and I'm talking about people from the Africas, which to me is the African continent and the Caribbean and places like Brazil, I include in the Africas. So people from the Africas are going to be impacted more severely. There will be more levels of trauma on top of this because of the way we grieve is very much hands-on. So you will find that you may not have seen a loved one that you normally would regularly visit each week. You might not have seen them a few weeks because of social distancing. That loved one may go into hospital. You may not see them for a few weeks because you're not allowed to go to the hospital. That loved one may die. You're not allowed to see that loved one in the hospital or at the funeral parlour because of social distancing. And then that loved one has their funeral. And in Leeds at the moment, if you're having a burial, you can have 10 people at the graveside, including the client or the person who's going to be managing the funeral. So then if you're from an extended family, you then are charged with the decision, well, who are the other 9 people who I'm going to say can come to our loved one's funeral? It's not just my loved one's funeral, it's our collective loved one's funeral. How then do I make that decision? And culturally, our funerals tend to be highly populated. It's not unusual for us to take the day off work to go to a funeral, whether we're related to that person by blood or whether we're related to that person. We call them auntie, and we know that they're not related to us by blood, but as far as we're concerned, they're family. We would be moved to go to that funeral under normal circumstances, and at this point in time, it's just not possible. Also, people from the Africas would want to repatriate their loved ones. Right now, that is not an option. It's not an option for a lot of the countries. There's a list of countries which are still allowing people who had left to come back home and be buried there. A lot of the African and Caribbean countries are not on that list. So we have to think how we're going to approach this, whether our loved one dies from COVID-19 or not. During this lockdown period, we are going to be experience more trauma in our death experience because of lockdown. My personal suggestion, and this is a personal suggestion, is we're going to have to be more imaginative about celebrating our loved ones that we lose further down the line. So it might be that whereas normally we would have about 2 weeks is about the average from the time somebody dies to the time of their funeral. Normally we would have all of that sorted, we'd get our order of service, and remember, we can't come together even as people who worship to celebrate the life of this person anymore. And a lot of us are, of faith, and removing that aspect is another additional trauma too. And we're not able to do that either. So it might just be a case of speaking to our preachers, our imams, people who are our brothers and sisters in faith, and saying, well, somebody has died. Please let's not forget them just because they've died during this COVID lockdown. I'm just letting you know right now, I'm planning something big and grand or small and intimate, whatever the case may be. But that person who dies does not deserve any less on account of the fact that we are on lockdown right now. We may have to just plan for the future, because we know that culturally coming together and celebrating a life is part of how we grieve. It doesn't mean we have to go without that aspect. It means we're going to have to think of doing it in a different way. And it can be in accordance with your personality type, the way your family does things, the way you culturally do things, the way you religiously do things, as long as it's suitable for you as an individual and your family and the person that you're celebrating. Do not think that COVID means you cannot celebrate someone you love or care for forever. The door is not shut. It just means just think a little bit further down the line. When this is over, this is what I'm going to do. Okay,
Xina, thank you so much.
You're welcome.
I think that's quite useful. We'll take it to heart, and it's something that on a personal level, I lost my dad beginning of this year, but not related to COVID. But I was able to mourn, I was able to travel, I was able to be together with the family. So I cannot imagine what the families are feeling like at this point in time. So thank you, that we should all celebrate each other. And we should all celebrate each other now. Now, we don't have to wait till later. Now, I'll pass it on the discussion to, I just want to say thank you to all the speakers. Pass on the discussion now to Kendi. I'm sure she's got questions. We'll try and wrap up. Thank you so much.
All right. So thank you all. I mean, how quickly 1.5 hours goes. You know, I mean, I'm looking at the time and I'm thinking we only have 12 minutes and there's still so much that we want to talk about. So we'll just quickly wind up. So I'll just go straight to the point. Dr. Mathias, so I'll just have a quick question, few questions, just one question for each speaker before we wind up. So Dr. Mathias, so I can see you've put in the chat that basically 30% of people have no symptoms at all. So that seems to be a problem. And in fact, Hashim had asked earlier that there are reported cases of people going to hospital for other ailments and whatnot. And then the next thing, the loved ones receive news that the person who walked into hospital otherwise okay has now passed on, and the death certificate comes back as COVID. Could you briefly enlighten us on that, please?
Thank you, Kendi. So from my point of view, because I work, so currently, you know, I'm working in intensive care, and basically what we have done is that to increase capacity, you know, we have had to stop all operating, and then so all the theatres are now intensive care beds, basically. So I will, you know, when a patient comes, you know, so I will only see them if they require level 3 care. So most of the decisions about who is going to come to us, you know, are taken by the intensive care consultants who get the referrals either from the ward or mainly from A&E. But so that decision basically is based on the severity of the disease. You know, it shouldn't include anything else. I know that, you know, capacity has been one issue that has been a major problem, you know, not only with COVID, actually, you know, with any, you know, sort of severe illness. Normally, you know, when we didn't have COVID, you know, intensive care capacity always runs at about, you know, 90% all the time. So there isn't much room for maneuver, and, you know, certain decisions are taken, you know, to not admit someone to intensive care, you know, based on the likely outcomes. But I think our counsellor, you know, did touch a bit, you know, about our response in Leeds, and what we have found is that Leeds, our cases, for some reason, we are an outlier. We had lower cases than predicted. I think at the peak of this here in Leeds, I think we almost always had capacity. So I would like to believe that in Leeds, nobody was denied, you know, admission to intensive care unit, you know, because there wasn't capacity. There was always capacity. So it just depends on how severe the disease is.
So in other words, we can rest assured that once we do go to hospital, sometimes what loved ones were concerned about is people not showing symptoms and then getting COVID. So chances are they already had it, is the thing, isn't it?
Yeah, and then I'll touch on about, because I think, you know, some people are, you know, asking.
We only have 8 minutes, Doc. We have only 8.
Getting worse.
Sorry.
And then, okay.
Sorry, we can't.
Okay.
Sorry, Doc. We only have 8 minutes. but we'll try and share as much as we can. And I just wanted to give Abigail and Xina just one last word, but thank you so much. So Abigail, if there's one thing that you can tell us about COVID from your perspective, just one thing you think you would say, if you learn nothing, if you do nothing else, do this, what would it be?
Follow the government guidelines.
Fabulous. Okay. Follow the guidelines. And if you don't know where to find them, you can find them where, Abigail?
You can find them online. You can give us a call, contact your local counselors. Give me a ring, call Kendi, the person asking me questions. She will answer you. The information is all over the place in the government guidelines. But I am free to take calls to tell you or send them to you if you do not have them.
Social distance, stay at home,
That's
ring
right.
for
Wash
help.
your hands, eat good
Wash your hands.
food.
Good.
If you don't have good food, give us a call. We will be there with some good food.
Good. Xina, first and foremost, really, you know, our heart goes out to you for that harrowing experience you and your family have had. And thank you so much for being very honest and open with us on that. And also, end of life is something that we seldom want to talk about, especially people of African origin. It's one of those taboo subjects, and I think we actually need to have another session to just talk about that. But what would you say, just one takeaway for us, especially during this time, the COVID-19 time?
Take good care of your mental health. Take good care of your mental health. This will be particularly difficult for us if we're family oriented and we find that we can't go home to our home countries and see people. They can't come over and see us. We can't go down the road and visit our loved ones the way we would love to. And my mother's on this call and I'd love to give her a hug and a kiss, and it's a struggle to know that I can't, and my sister's there too. So I would say this is a really important time to take care of your mental health. Stay happy, stay connected, take care of your mind as well as your body.
Great, thank you. And yes, hi Auntie Thelma, and hi Gay, we can see you there. Yeah, so thank you very much for that. Now also I want to draw your attention to something. We have Dr. Patricia Mutunga. I think she's just left her thing running and gone off somewhere. So she's the head of stem cell and immunotherapy for the NHS in Leeds, and she has put a link on the chat box. So please have a look at that to see oh, there she is. She's waving at us. Yes, Doc. So she has put some information there. Oh, we can't hear you. Do you want to unmute her for a second, Sam? Oh, there you go. Unmute her for a second. Hold on. Doc, we can't hear you. Sam? Yeah, unmute. There you go. So 2 seconds. Mm-hmm.
Sorry, I was here all the time. My camera was facing the world. So one thing I was just about to post is, please, if you're worried about your health as a BME, get risk assessed by your manager. Talk to your manager. You can actually get measures in place put so that you're not frontline.
Yeah.
For BMEs, that's happening with us now. I'm doing risk assessments next week to excuse people who I think they're at risk. So don't suffer in silence.
Fantastic. Thank you, Doc. So if you work frontline for the NHS or you're working frontline anywhere, you can be risk assessed if your BAME is what Doc is saying, and look at that link to see the work that they are doing. So you should not be forced to take on shifts that, you know, and be exposed unnecessarily. Okay, so Dr. Mathias, thank you so much. I know you have so much to share and we have so many sessions, so many questions. I think what we will probably do is get another session together. Is that, yeah? So I think that's what I'm getting. I'm getting lots of nods, people saying yes, and we can perhaps focus on that aspect from a medical perspective, because I think we need to understand it a lot more. So thank you very much, Doc. Thank you everybody for joining us. It's been great, and for those of you who asked questions, yeah, and Xina has put more information there. We'll put this together, we'll share it. It's our first one, so thank you also for bearing with our IT issues. but Sam did a fantastic job behind the scenes to help us stay here and be safe and stay connected. So if you would like to get in touch with us, Sam, we've got some information. So basically, if you want to get in touch with us, you can email us at leedscommunities@gmail.com. Over and above having talks such as this one, we are also helping members of our community with food and all sorts of support that we can give them. So please feel free to get in touch with us if you've got any money or basic essentials or food that you are happy for us to share with our loved ones. So leedsafricancommunities@gmail.com. I think Sam hasn't found the slide yet. But we will leave it there. When it does come on, I'll leave this running for the next 2 minutes. Yeah, and thank you all for coming. Thank you. And thank you, Lucy, for taking us through. Yeah, and that's a slide with all the information you need. Thank you. So feel free to leave when you are ready. Thank you very much. Thank you.